Good morning, everyone. It's our pleasure to welcome you to our fourth Patient Family Colorectal web meeting. This is a very special one as we are celebrating the 40th PSARC anniversary. So first of all, I would like to say we are overwhelmed about the amount of people that wanted to join this meeting from all over the world. There were so many good questions. We tried to address each of them, but some of them are so complex that we could possibly dedicate an entire meeting to it. So if for some reason your question is not fully addressed, don't hesitate to contact us after the meeting. So my slides are not passing now. Let me see if I can. Okay, now it is. So I just want everybody to go back a little bit and remind ourselves what was happening in 1980. So at that time, there were no computers, no internet. Cell phones were already invented, but they were not widely available. International or long distance calls were a luxury. So it was a very different world from what we experience now. And I think during this pandemic, it's good that we can have an event that brings us all together. Other important things for Star Wars fans, The Empire Strikes Back was released in 1980. Pac-Man was the most famous electronic game at the time. For those that like terror movies, The Shining was released, and The Shining was actually inspired by a hotel here in Colorado named Stanley. And sadly, John Lennon was murdered. CNN was also launched in 1980. But the reason why we're all here today is because in 1980, Dr. Pena had an uneasy feeling. He was not satisfied with the way anorectal malformations were repaired. And I think when we all experience uneasy feelings, not all of us know how to deal with it, but we have to think that sometimes dissatisfaction brings good. And I think the PSARP is an example of it. Dr. Pena was not happy with the visualization of the structures, with the results, so he decided to approach in a different way. And that's why we're here today. So I'm gonna invite Dr. Pena to tell us about the anorectal malformation, the 40 years journey.
Good morning, everybody. It is a unique privilege and honor for me to talk to all the parents of children. I'm sure many of those who are listening and watching this are my patients, which I feel very grateful for your confidence, for your cooperation, and for the privilege to allow me to take care of your children and then to follow them until many of my patients are now adults, and we keep trying to help them. And this picture shows the building of the institution where I was working in Mexico in 1980. I worked there for 14 years. I had the privilege of being the chief of surgery of that beautiful institution. Now it's called National Institute of Pediatrics. I trained at Boston Children's Hospital, where I learned to take care of patients with anorectal malformations in the traditional way. And all the operations were kind of blind. We were trying to repair the malformations without really seeing what we were doing. We were approaching these patients through the abdomen or from below, but we never saw directly the place where the bowel joined the urogenital tract. As a consequence, when we were trying to repair those malformations, frequently we injure the urogenital tract, meaning injure the urethra, the vas deferens in the males, the seminal vesicles, the prostate, the urethra, and in the female, the vagina, and so forth. So and in addition, the results in terms of bowel function were dismal, were very poor. But that's what I learned. And when we learn from our professors, we try to repeat what we learned from them. I went back to Mexico to work on that institution, and I was always curious to try to see the intrinsic anatomy of the malformation. And I came up with an idea, and I took my idea to one of the international meetings, questioning the old traditional techniques. And of course, my ideas were rejected, and people didn't like very much that I was questioning the gurus, the masters, the professors, the experts. So I went back to Mexico, and on that particular day, August 10, I decided to explore patients with anorectal malformations with an incision in between both buttocks. By doing that, I would be able to see exactly the anatomy of this malformation. And I was trying to see if the anatomy described previously by other doctors was there, and actually it was completely different. So that's where everything started. Then then the next step was to convince all the surgeons all over the world about the new findings and the new technique. The results with the new approach were much better than before. So, and I was fascinated because I thought that because of that approach, all patients with anorectal malformations would be normal after an operation. But very soon I learned the main lesson, which is that when we talk about anorectal malformations, what people know as imperfodanos, we are not talking about a single defect. We are talking about what we call a spectrum of defects. In other words, there are what we call good anorectal malformations and very bad anorectal malformations. So many children are born with imperfodanos, but in addition, they don't have nerves, they don't have muscles, they don't have the necessary anatomic structures in order to repair them successfully. So very soon I learned that yes, the approach was much better. And for those patients that were born with good anatomy, we could make them almost normal. But for those patients that were born with serious deficiencies, there was no way to improve them. So, and that's what the reality that we learned. But anyway, we were able to improve the techniques and improve the results. So before 1980, the operations were basically blind and hard to believe. It was in the 1980, at the time when we already were beginning to manipulate the genetic material, at the time when we already had a man in the moon, and we were still doing blind operations with very poor results. Since and we until today, we have now operated posterior side cell 2,652 patients, and we are still learning because, as you know, human beings, there is not one human being identical to another. We are different one another. So every time I explore surgically a patient, we find different anatomic details. Every patient is different. What is beautiful about having experience is to be ready to recognize the variation, the differences between one case and another, and to be able to adapt our surgical technique to the different anatomic variants, and we are still learning. And I suspect that if I live another 40 years, we'll continue learning about these malformations. So with the new approach, we were able to see the real anatomy, and we were able, something very important is to avoid the damage to the urogenital structures. With the old techniques, we see now adults that have problems in the urinary tract, male patients that have no sexual life, they have no erections, they have no ejaculation, they have urethral strictures, urinary incontinence that was not there and was provoked by a bad operation. And in addition to learn how to separate the rectum from the urinary tract, we work with an electrical stimulator to see the best possible location of the rectum, to put the rectum within the limits of the sphincter that gives contraction and bowel control. And of course, we had better functional results. With the new technique, we learn that it is not true that malformations are divided into high and low. People, unfortunately, even surgeons still talk about the high imperfodamus and low imperfodamus. It is as simplistic and misguiding as to say that human beings are divided into tall guys and short guys, or human beings are divided into bad guys and good guys. Mother Nature doesn't work that way. Everything is in the form of a spectrum. Human beings are short, and it's a spectrum that goes to very tall and very short, or very good and very bad, and all of us have a little bit of bad and good. That's what anorectal malformation. So we have to create a new classification. Because the classification is important because when we make a specific diagnosis, that specific diagnosis referring to a specific malformation means that the patient is going to have a specific prognosis and needs a specific operation. So we have a new name for each malformation. So when the parents call us and said, my son was born with a high imperfodamus, doesn't mean anything. We have to go and say, be more specific. High, the surgeons include into the high category many malformations with completely different prognosis and completely different treatments. And that's why we don't accept that. So when the doctors tell you that your son has a high, you have to say, that doesn't mean anything. Tell me exactly what malformation, where the rectum was specifically located. How is the sacrum of my son? The quality of the sacrum, what people call the tailbone, represents a very important prognostic factor. A patient that is born with no sacrum will never have bowel control. And that is something that we can learn in the first 24 hours of life. In addition, some patients are born with something called tether cord, and that we can learn the first couple of days after the baby is born. So when a baby is born with an anorectal malformation, the parents must learn to demand from the doctors to have the full information related with the characteristic of the malformation in order to determine the future prognosis. Because we have tried to follow as much as possible all those patients that I operated all over the world. Now we have adults and we ask them how they're feeling. And so now we have learned to tell the parents what's the future of the baby. And we can tell them that in the first 3 days of life. So the first thing that parents should demand, I want to know what's the future of my baby. Sometimes we have to tell them bad news. But it's better it's better to tell bad news in order for the parents to adjust their expectations rather than keep them ignoring the reality of the child. So in order to determine what's the future of the baby, the first thing to know is the type of malformation. Specifically, the rectum in a male was connected to the bladder, was connected to the urethra, what part of the urethra. In a female was a vestibular fistula, was a vaginal fistula, was a cloaca. Not to say high and low because it doesn't mean anything. And then the second, how is the sacrum? And we have a specific way to measure the sacrum and correlate with the prognosis. We have a specific ratio that we can calculate, and we can, when this ratio is less than 0.4, the chances of bowel control are very, very poor. And the parents must know that from day one. And the absence of presence of tether cord, it takes a simple ultrasound of the spine done in the first few days of life to make the diagnosis of tether cord. And tether cord has important implications in terms of urinary control. Another thing that we have learned extremely important, there are malformations in which the surgical technique to repair the malformation is extremely simple. And so the surgeons don't need a special training. In anorectal malformations, particularly in cloacas, the quality and the characteristics of the surgical technique is crucial for the future of the baby. And during the main repair operation, what happens there also provokes a lot of benefit or damage to the baby. As I explained, the malformations are in the good side of the malformations. If you do a good operation, the patients are going to be basically normal. The sad part of the story is that as we are talking right now here, in some place in the world, a baby with a good malformation is receiving a bad operation, poor surgical technique, non-meticulous surgical technique. And that bad operation would provoke urinary and fecal incontinence for life. So we have a long way to go in training young generations of surgeons to, to be more dedicated to and concentrate in performing delicate, meticulous surgical operations. So I cannot overemphasize the importance of a delicate surgical technique. The good surgical technique is very much related with the number of cases per year that the surgeon performs. So now the parents have learned when you take your baby to an operation, to a hospital, you have the right to ask, doctor, with all due respect, how many cases like this do you do per year? And they have we doctors have the obligation to tell you the truth. And also you can ask the hospital, how many cases of unrectal malformation this hospital has per year? So you would not like to allow a surgeon to operate in your son, knowing that that surgeon performs one case per year. So this is like the piano playing, like a violin player. You have to repeat and repeat and repeat and develop experience. And that's why now we are living in the era of centralization of cases. There are countries like England where the government decides that certain malformations should be treated only in a single institution that has the resources, the expertise, and the number of cases. We cannot implement that easily in the United States because the United States has the more freedom in that the government doesn't play a role in that, but the parents can do that. And everything started, for instance, in the similar association to the pull-through network. There is another association in Italy, and the Italian mothers went to the government and demanded that every hospital has the obligation to report the number of cases of unrectal malformations that they have per year. And now we are doing the same kind of parental revolution in Greece also. They are creating the same and they are demanding the same. So a technical surgical error that happened in 2 minutes during an operation may provoke fecal incontinence for life. In 1982, I had the idea that perhaps using the same approach, an incision in between both buttocks, using an electrical stimulator, I could try to repair a malformation that had been a real challenge until that year. It's called cloaca in females. As you can see in this slide, normal females are born with 3 perineal orifices. One is the urethra, the other is the vagina, and the other is the rectum. But in cloaca malformations, those 3 structures come together to form a common channel and opens in a single orifice in the bottom. So the challenge was to separate those 3 structures and put them in the right place. And in 1982, I performed the first operation. And again, I was fascinated because I was able to repair the malformation. And that particular patient from 1982 got married, had a baby, had sexual life, bowel control, and urinary control. And I thought that all the cases of cloaca would be like that. I was fascinated. Very soon, I started seeing that there are cloacas and cloacas. There are malformations very complex that are born without the necessary elements to be repaired. And so many of them cannot be repaired completely, but many of them are. Before 1982, these malformations were not repaired. There were anecdotal reports of that, but no real repair. So then we learn, of course, that like all congenital malformations, anorectal malformations, babies are born with other defects. 50% of them have some sort of urologic problem. 30% have some form of spinal problem. Sacral malformations, of course, very important. 25% of them have tethered cord. 10% of them required some kind of surgical operation or at the service of a cardiologist. 8% have esophageal atresia. There's a group of patients with malformations in the extremities. And of course, in the cloacas, all of them have gynecologic concerns. And of course, many of them have chromosomal abnormalities. So very soon after I started working from Mexico, moved to New York, where I worked for 20 years, we received patients from all over the world. But many of my patients had to come to New York for me to repair the malformation. Then they have to go to another institution for an expert in urology, then to another institution for an expert in orthopedics. So we felt the need to have a multidisciplinary center. And we started talking about that to other institutions. And there was one particular institution, Cincinnati Children's Hospital, who embraced our idea. And we created the first multidisciplinary colorectal center. And we're very successful also there. And then from 5 years ago, we moved to beautiful Denver, Colorado, where we created this same idea of a multidisciplinary colorectal center. We work in collaboration with great professionals, and all this care of all these malformations can be done in the same institution, and we are very happy about that. Again, and then very soon, following, which is extremely important to follow these patients, to follow to the last consequences. I will be seeing patients and advising until the last day of my life. It's extremely important because we learn many things from that. Because if this is a spectrum, as I said, at least 25% of our patients have no bowel control. That's much better than before 1980, but it's still a serious problem. And the question is what to do about that. Traditionally, surgeons operate on a patient, and once we finish the operation, they send the patient back to the internist, to the general practitioner, to the pediatrician, and say, I have done my job, now it's you follow the patient. We don't agree with that. We believe that we are morally obligated to follow our patients because the operation is only the first step. So what happens after that is extremely important. And I feel that we are morally responsible for that. And that's why we created what is called bowel management program. We have to help our patients. We cannot make them normal, but certainly we can help them in many ways. Because the majority of our patients with anorectal malformation suffer from constipation. And because at least 25% of them suffer from fecal incontinence. What to do about them? Just abandon them? Pediatricians and gastroenterologists don't know about that. So we have to do something, and we created this program. By giving a specific formula, specific type of enema to every patient that has to be different in every patient, we can at least keep the patients completely clean in the underwear, which is a big difference from, fecal incontinence is a devastating problem. The patients suffer from very serious psychological problems. They live in a closet. They are not accepted at school. They are discriminated. They are shy. They have problems with establishing relationship with the opposite gender. Sometimes they commit suicide. So keeping a patient completely clean make them socially acceptable. So that's the big difference in bowel management. Now, bowel management is something that institutions don't like to do, and many doctors don't like to do. You know why? Because first of all, we are surgeons. We like to operate, and bowel management doesn't pay well. Insurance companies do not recognize bowel management as an important entity. Easy, they pay for an umbilical hernia that takes 15 minutes to repair, but not for bowel management. So nobody wants to do that. And it takes actually one entire week for us to implement our program and to keep a patient clean. Many doctors all over the world prescribe enemas. Bowel management is not to prescribe enemas. Bowel management is to find out the best possible enema for every patient. And that takes 1 week and several visits and changes in the formula of the enema. So we are very proud of our bowel management program that has been growing, and we really believe that the bowel management program changes the quality of life of many patients for good. And finally, we have been facing this situation in which my patients now call me, and they are 20, 30, 40, 50 years old, and they have problems, some sequela from the malformations. And who is going to take care of them? And they go to adult hospitals, and the adult doctors don't know much about this. Our cloaca patients, they go to the gynecologist, and they say, "Doctor, I was born with a cloaca." And the gynecologist says, "What is that? Excuse me, I never heard that." So they feel very disappointed. They feel desolated. So we are, again, morally obligated to follow those patients and to try to help them. And that's why we have a specific collaboration with our colleagues, the adult gynecologists, adult urologists, adult colorectal surgeons at the university hospital next door. And sometimes we go there to operate. Sometimes we invite the adult surgeons for them to learn about these malformations, but we cannot abandon these patients. So as you can see now, what started with a kind of bold, brave approach to try to do something better for the patients, now is growing and it has so many implications that that will keep us busy for the next 100 years. Um, and what's next? Well, what happened in my lifetime in terms of advances in the science of technology are much beyond what my imagination could conceive. All the advances in medicine and surgery are fantastic. When I was a medical student, I never imagined that this could happen. And therefore, I'm an extremely optimistic human being. Sometimes too optimistic, perhaps, but I believe that the new generation of scientists will come up with answers for this. We'll be able to manipulate the genes. We'll be able to make much earlier the in utero diagnosis beyond ethical and religious concerns. They will be able to manipulate this to avoid all this. And also, scientists will come up with better ways to make the bowel function, for instance. If we could come up with a pill that you take and provokes a bowel movement within the next 30 minutes and empty your colon, and then another pill that paralyzes your colon, you don't need sphincters, you will be completely clean. Something similar with the urinary tract. So there are many possible approaches to the functional sequela of these malformations, but I'm sure that I believe in the young people. I believe that these future scientists are walking around. The Einsteins, the Newtons, the Darwins are walking around looking for an opportunity, and they will come up with better answers. I don't believe that the old guys were better. I believe that the young generations are better than us. So with that, I want to thank you very much for listening to this, my obsessive ideas about the management of anorectal malformation. We are here to help you anytime you want. Thank you very much.